Hi, good morning. My name is Jason Waspy. I'm a cardiologist at Mass General Hospital. I direct our program in health outcomes research in the MGH Cardiology Division, and I'm an associate professor at Harvard Medical School. I am the chair of New England CEPAC, and I am very happy to invite you all to join us today. We are very happy to have all of you here for what I know is going to be an extremely important meeting. I'd like to begin by introducing my colleagues on the CEPAC. They're going to introduce themselves. And at the beginning of every meeting, we always ensure that our speakers disclose any financial relationships with industry. Every member of our CEPAC council today who is present has met the ICER conflict of interest policy. So as you introduce yourselves and your work, please just note if you need updates to your prior declarations. And I'm going to go through in alphabetical order. And I'd like to start with Dr. Rob Azeltine.
Good morning. I'm Rob Azeltine, professor and chair of the Division of Behavioral Sciences and Community Health at the University of Connecticut Health Center. Much of my work is focused on mental health and suicide prevention, and I have no updates to my conflict of interest.
Thanks so much. Dr. Austin Fracht.
Morning, Austin Fracht. I am a health economist with affiliations at the Boston VA healthcare system and with the BU School of Public Health and the Harvard T.H. Chan School of Public Health.
Thanks so much. Rebecca Kirsch.
Good morning. I'm Rebecca Kirch with the National Patient Advocate Foundation, Executive Vice President of Policy and Programs, and I have no conflicts and no updates.
Thank you. Dr. Steve Kogan.
Good morning. I'm a professor at the University of Rhode Island College of Pharmacy, where I specialize in medication utilization and outcomes research. And relevant to today, I also worked as a pharmacist at a psychiatric specialty hospital for many years. I have no updates to my conflict of interest disclosures.
Thank you so much. Dr. Don Kreis.
Good morning, everybody. I'm Don Kreis. I am the utility ratepayer advocate in New Hampshire, but I'm really here today in my capacity as a person who very proudly raised to adulthood a excellent young person who lives with cystic fibrosis, and so I'm here as a patient and family advocate. And I have no new conflicts of interest to disclose, or even any old ones.
Thank you, Don. And a new member, Dr. Julie Coopers.
Hello, everyone. I'm Julie Coopers. I am a nurse practitioner and healthcare researcher and the VP of Clinical at Alera Group. And I have no updates to my conflict of interest.
Thank you. And we're so happy to have you join our panel. Dr. Tara Lavelle.
Hi, everyone. I'm Tara Lavelle. I'm a health economist and assistant professor at Tufts Medical Center. And some of my work is focused on the value of interventions for mental health. So happy to be here today. I have no updates to my conflict of interest.
Dr. Aaron Mitchell.
Hello, I'm a medical oncologist and health services researcher at Memorial Sloan Kettering Cancer Center in New York City, and I have no updates to my conflict of interest.
Thank you. Dr. Stephanie Nichols.
Good morning. I am a board certified psychiatric pharmacist. I am an associate professor at the University of New England School of Pharmacy in Portland, Maine. I am also adjunct faculty for the in the Department of Psychiatry for the Tufts School of Medicine, and I'm on faculty for the Maine Medical Center Addiction Medicine Fellowship and Psychiatric Residency Program. And I also have no updates to my disclosures.
Thank you. Another new member, Joe Porter.
Hello, thank you. I'm Joe Porter. I'm the Chief Strategy Officer at the New Hampshire Center for Justice and Equity. So my focus was largely on the health equity side.
Thank you so much. And a third new member, Dr. Joe Ross from Yale.
Hi, my name is Joe Ross. I'm a professor on the faculty at Yale in medicine and public health and a general internist. I'm happy to be here. No updates on my disclosure.
Thank you. Jean Ryer.
Hi, everyone. Jean Ryer. I'm director of the New Hampshire Citizens Health Initiative, and I lead work at the University of New Hampshire Institute for Health Policy and Practice on delivery system and payment reform. Also relevant for this meeting is I've been probably a chief instigator for our Project Echo Hub work on substance use disorder and behavioral health, and lots of overlap with this work. I have no conflicts of interest and no updates.
Thank you. And I think this is your last public meeting with CEPAC, so it's just been such a joy to work with you on this over the years. I think it's been 10 years that you and I have served together on this panel. Dr. Jason Schwartz.
Good morning, I'm Jason Schwartz. I'm an associate professor of health policy at the Yale School of Public Health. My research looks at regulatory and policymaking issues around pharmaceuticals and vaccines and other medical technologies, and no conflicts and no updates to share.
Thank you. And our last new member, our last one on the panel, we're so happy to have you join, Dr. Rishi Wadera.
Good morning, everyone. I'm a cardiologist at Beth Israel Deaconess Medical Center and an associate professor at Harvard Medical School and the Harvard School of Public Health. And I'm also the associate director of the Smith Center for Outcomes Research, where I lead a research program focused on healthcare policy and value-based care. I have no conflicts.
Thank you so much, Rishi. So I'd like to move on now to introduce some individual patient and clinical experts. And similar to the CEPAC, we just love you to introduce yourselves and declare any potential conflicts of interest. So I'd like to start with Diana Chow.
Hi, I'm Diana Chow, and I'm the executive director at Letters to Strangers, the largest global youth mental health NGO. And I'm also a person with lived experience with the topic at hand today.
Thank you so much for joining us. Naomi Mathis.
Hi, I'm Naomi, and I am the Assistant National Legislative Director for DAV, Disabled American Veterans, and I am a combat veteran, and that deals with, has been dealing with PTSD for a lifetime.
Thank you for joining us. Dr. Jessica Maples-Keller.
Hi, good morning. I'm Jessica Maples-Keller. I'm at Emory, assistant professor and clinical psychologist in the Department of Psychiatry. I do research on using translational models to improve PTSD and anxiety disorder treatment and research on novel psychedelic interventions. And as far as potential conflicts, I have received funding previously from Compass Pathways and MAPS for research studies. I have received consulting payments from Otsuka and Compass Pathways, and I have a current ongoing trial looking at MDMA in combination with prolonged exposure therapy.
Thank you. And finally, Dr. U.R. Halverson.
Good morning and good afternoon from Norway. My name is U.R. Halverson. I'm working as an associate professor at the Department of Psychology at the Norwegian University of Science and Technology. And I also work as a consultant clinical psychologist at St. Olav's University Hospital here in Trondheim. I have no financial conflict of interest to disclose.
Thank you. And we're just so grateful to all of you patients, patient experts and clinical experts for your joining us and for your expertise, which I know is so important to our process here. So going forward, any other speakers that I haven't introduced, including policy roundtable participants and individuals making public comments, should I declare any financial relationships with the industry or any potential influences on their judgment when they speak. And we will also simultaneously present this information on slides. And so with that, I'm delighted to introduce the new president and CEO of ICER, Sarah Emlund.
Dr. Wassi, thank you so much. Before we get started today, I wanted to provide a warning to those in attendance that some topics and stories shared today may be difficult to hear. While we don't know the specifics of what those providing public comments may say, the traumas that patients with PTSD have experienced are wide-ranging, and the experiences of some patients speaking and being discussed today may touch on difficult issues like sexual assault. As always, we encourage all participants and attendees of this meeting to center their well-being when deciding whether or not to attend. I also want to just take a moment to introduce the other voices that you will hear today. David Rind is our Chief Medical Officer and served as the Senior Management Lead for this topic. Brett McQueen is the lead modeler. He's a health economist that we'll hear from later. Soon we'll hear from Dr. Reem Mustafa, who's a physician and the evidence author for today's review. And Steve Pearson, now serving as special advisor to ICER, will be moderating the voting questions and the policy roundtable later. Next slide. Whenever we gather to talk about a new intervention, we always want to start by remembering why we're here today. And in talking to many different patients and their families throughout this review, this quote really captured a lot of what we care about when we think about the clinical effectiveness of a new therapy. This person shared that they have a lot of nightmares. They have to do with what happened to me. There are places that remind me of my trauma, and there are people that remind me of my trauma, and I would avoid those at all costs. So basically, I just wanted to be alone. I don't want to try to explain it to people. I didn't want to have to go over my experiences every single time. I trusted no one, even my own family. I started believing that I didn't deserve help, that I didn't deserve to be happy. Next slide, please. We commend those who shared their story about living with PTSD, and we want to also say this is an important milestone potentially for thinking about the treatment for PTSD. And if this treatment gets FDA approval, then that's usually a day of celebration for people dealing with a condition. But that's sort of the beginning of the questions that we need to ask as a society, because we have other questions that will be raised. What are the risks and benefits of the new treatment? How does this treatment fit within all of the other things that we might have available to treat a particular condition? And what are the reasonable prices and costs to patients, the health system, and to society generally? And what lessons are learned from our examination of these questions to help make our policymaking grounded in evidence? Those are some of the questions that we hope to answer today. Next slide. When we think about doing this work, ICER remembers that the goal is to think about having a healthcare system where prices are aligned with value so that we have an affordable and accessible healthcare system for everyone. And we should always remember the people who are harmed by rising healthcare costs. So on this slide and the links below, we've mentioned some of these stories before, including the Wards of Chicago who went $80,000 in debt because their twins were born prematurely. Sherry Foy, who went into bankruptcy because she had to have surgery to remove her colon. And the Bucks of Arizona, who were denied care because they had debt at the doctor's office from previous care that they had sought, and then they had to go to the emergency room. And recently, the state of Delaware shared that they were going to have to increase healthcare premiums 27% in order to afford rising costs that they attributed to outpatient medical procedures, specialty drugs, and emergency room visits. Next slide. We remember these stories, and we also remember that we are centering the lived experience and the needs of patients with PTSD, because that is the topic today, while still thinking about the impact that decisions made about price and access will have on other people in the healthcare system. This population health perspective guides the work that we do, because we believe that we can have fair prices and fair access for patients with PTSD in a way that does not harm other people in the healthcare system trying to seek care. Next slide. We are ICER, the Institute for Clinical and Economic Review, a nonprofit research organization conducting this research. We have convened our New England CEPAC, which Jason did a beautiful job introducing this morning, our independent appraisal committee, which will be deliberating and voting on the evidence today. Next slide. We are very transparent about our sources of funding, and you can see a list of all of our contributors on our website. Please know that all of ICER's research is funded by nonprofit foundations and individual philanthropy, while contributions from manufacturers, health plans, and provider groups support only our policy summit and not our research. Next slide. Just quickly, for those not familiar, perhaps it's your first ICER meeting. This is the end, or towards the end of a 8-month-long process where we talk with patients and clinical experts in the manufacturer to try to scope our research questions. We partner with leading academics, like I mentioned, Dr. Reem Mustafa and Dr. Brett McQueen, who you'll hear from today. We take public comments several times, revise our work, and respond to those public comments in an effort to bring transparency into the discussions and the deliberations that we're having about the evidence of a new therapy. We are thankful for the expert reviewers who contributed their suggestions to our evidence review. They should not be assumed to have endorsed any part of the report, but we thank them nonetheless for their contributions and their feedback. And when you're thinking about following along at home today, the PTSD evidence report is available. It has all of the detail that the CEPAC has already read and digested as part of the deliberations today, that goes through the background, the patient and caregiver perspective, the comparative clinical effectiveness, the long-term cost effectiveness, and benefits beyond health and special ethical priorities. Next slide. Again, for those who aren't as familiar with how ICER approaches its work, we take a long-term value for money perspective when thinking about the comparative value question. And things in green are things that are typically measured in a cost effectiveness analysis. Things like longer life, if it's a life-limiting condition, fewer side effects and feeling better for any type of condition, and also overall costs. But we center our conversation about special social and ethical priorities and benefits beyond health, because we are the first to admit that a cost effectiveness model is only one input into a conversation about value. Next slide. You've almost survived the opening remarks. We'll be headed to the presentation of the clinical evidence next, when then we'll also talk about the economic model. We'll hear from patients and clinicians in the public comment section. After a lunch break, the New England CEPAC will deliberate and vote on the evidence. And then following another vote, we will have a roundtable discussion focused on the policy implications of what we know about the evidence for this new therapy for PTSD, closing with some reflections from the New England CEPAC members themselves. And with that, it is my pleasure to be introducing Dr. Reem Mustafa, who will walk us through the clinical evidence presentation. Reem, over to you.
Thank you very much, Sarah, for the introduction. Hello, everyone. I'm Reem Mustafa, and I'm here in the role of the evidence author. And next slide, please. I have worked with the members of the ICER team, specifically Dimitri Nikiden and Emily Nan, and none of us have any disclosures to share. Next slide, please. Talking about post-traumatic stress disorder, it is a complex psychiatric disorder associated with substantial disability and poor quality of life. It can involve nightmares, flashbacks, intrusive thoughts, and avoidance of trauma reminders. In the US, about 13 million adults, or 5%, experience PTSD symptoms annually. And in 2018 alone, the total economic burden beyond normal healthcare costs for PTSD in the US was more than $230 billion. PTSD is more prevalent in certain subgroups like women, veterans, and racial and ethnic subgroups. Next slide, please. We talked with patients with PTSD, and we reached out to over 20 clinicians, 15 patients advisory advocacy organizations, and hosted a focus group and interviews with individual patients. PTSD makes daily activities extremely difficult for some patients, burdening patients and caregivers. Accessing trauma-focused psychotherapy is challenging with high dropout rates. And we also learned that despite trying various treatments, many still report persistent PTSD symptoms. Next slide, please. When we discussed with patients, we gained some insights where patients expressed concerns over lack of new FDA-approved PTSD treatments in 20 years. Some patients self-medicate or experiment with illegal and unproven compounds out of desperation. Patients perceive that successful therapy reduces symptom severity, builds coping skills, and alleviates suicidality, and fosters an autonomy without medication reliance. Next slide, please. There are treatments that are considered standard of care in the management. And I'm going to say that the trauma-focused psychotherapies is considered the main part of, or the first-line therapy. And these trauma-focused psychotherapy are really short-term therapies, ranging from 8 to 12 or maximum of 20 sessions. There is a variety like prolonged exposure therapy, cognitive behavior processing therapy, cognitive processing therapy, and so on. And these are the therapies that the main guideline in this space actually recommend and agree on, with some minor differences. Additionally, patients could use some pharmacotherapy, but I just want to highlight it's not only using SSRIs as medication. Most of this has to be associated with additional counseling as well. Next, please. So when we talk about MDMA-assisted psychotherapy, it is consistent of methamphetamine capsules to be used in combination with psychological interventions, including psychotherapy and other supportive services from a healthcare provider. The MDMA-assisted psychotherapy protocol in the trials required approximately 42 hours of therapy with 2 therapists per patient. That's a total of 84 therapist hours. And doses that range from 80 to 180 milligrams of the MDMA per session. Now, many may ask why all these number of therapist hours, and it's laid out here: 3 90 minutes preparation session, 3 8 hours MDMA-assisted psychotherapy session, and 9 90 minutes integrative integration sessions. The FDA has an advisory committee meeting on June 4th, and also is expected to have a decision by August 14 of this year. Next slide, please. When we did our review, we have focused our review on adults diagnosed with moderate to severe PTSD. The intervention we were interested to evaluate is MDMA-assisted psychotherapy. And we had 2 questions in mind. The first question compared MDMA-assisted psychotherapy to LICO-specific non-assisted psychotherapy, LSNAP for short, which served as the control arm in the pivotal trial, but is not an established form of standalone psychotherapy. So that was the first question. The second question was comparing MDMA-assisted psychotherapy to short-term trauma-focused psychotherapy for PTSD, like CPT and prolonged exposure. Next slide, please. With that, we now will start discussing the clinical evidence. And we have identified 2 main phase 3 trials, the MAP1 and MAP2 trial. And as you see in front of you, each trial had about 100 patients with age in about 41 or 39 years on average. These patients suffered from PTSD for a long time, 14 or 16 years on average. And all the patients included in MAP1 had severe PTSD, and majority, 3/4 of them had severe PTSD, but also MAP2 included some with moderate PTSD. And when we talk about CAPS-5, which I'll mention later, but it is a tool that is used to evaluate the severity of PTSD. And you can see from the scores that are 39 and 44 on average, that these again were patients with moderate to severe PTSD. And prior lifetime MDMA use was not minor. It was 32% and 46% in MAP1 and MAP2 respectively. Next slide, please. Now, there's an issue that we really want to address, and this is maintenance of blinding. The psychoactive and psychological effect of MDMA make it difficult to maintain blinding of participants and therapists. And it was evaluated in MAP2, 94% of participants actually who received MDMA correctly guessed their assignment treatment. And 70% of those who received the LSNAP arm also correctly identified their assignment. While MAP1 did not have a formal evaluation, but it was a pretty comparable finding. Maintenance of the blinding among the trial therapists was not formally evaluated in either of the trials, but again, the type of treatment make it quite plausible that blinding was not maintained. Next slide, thank you. Primary treatment goals, reduction in PTSD. CAPS-5, which is short for Clinician Administered PTSD Scale for DSM-5. It is a 30-item questionnaire from 0 to 80 total score, and it corresponds to the DSM-5 diagnosis of PTSD. It requires the identification of a single index trauma to serve as the basis of symptoms inquiry. And the reason I'm mentioning this is because, as you all know, many patients with PTSD sometimes suffer from more than one major trauma. Now, it is well established that CAPS-5 is the reference standard tool that is used in this space. The primary outcome when we look at the effect of these medications in the trials is a change from baseline through 18 weeks. And they looked at responders, which is people who had more than 10 points decrease in the CAPS-5. They also evaluated loss of diagnosis, which is no longer meeting the symptom criteria, and remission, which means loss of diagnosis and a total of CAPS-5 score of less than or equal to 11. Next slide, please. Now, when we look at the first question, which is MDMA compared to the control in the trial, the CAPS-5 score changed with a mean difference of minus 10.18 in the MDMA versus the LSNAP. You can see that the confidence interval goes from 6.5 to 13.8 minus. There is no established clinically meaningful threshold on CAPS-5. However, collaborators have agreed with FDA and established a 10-point as clinically meaningful difference. So in the trial, CAPS-5 with a minus 10.18 barely meets that 10-point difference. The standardized effect size, or what we call COIN-D, between the two groups was 0.8, suggesting a large treatment effect size. And when we looked at MDMA and compared it to LSNAP, for the treatment responders, there were 30% increased chance of treatment responders. There was 70% increased chance of achieving loss of diagnosis, and there were almost 3 times more chance of meeting criteria of remission when using MDMA compared to LSNAP. Next slide, please. When we look at durability of treatment effect, and phase 3 trial participants showed reduction in the PTSD symptoms 2 months after the final experimental session, demonstrating short-term health benefit, and long-term follow-up data from MAP1 and MAP2 are not yet available. Next slide, please. When we talk about harms, a common adverse event with MDMA-assisted psychotherapy include muscle tightness, decreased appetite, paroxysm, hyperhidrosis, fatigue, restlessness, and insomnia. Transient increase in blood pressure and body temperature and heart rate were observed with MDMA-assisted psychotherapy, and there is limited evidence on risk of MDMA-assisted psychotherapy abuse, MDMA abuse or cardiac events due to short-term follow-up. Next slide, please. Continuing on harm, there is a high baseline risk of suicidal ideation among patients. About 90% of trial participants with positive lifetime suicidal ideation. The risk of suicidal ideation in the trial was about 0.89. So we do not believe it's that there is an increased risk based on the data we have. MDMA-assisted psychotherapy lowered the risk of treatment withdrawal with a relative risk of 0.03. However, higher rates of discontinuation occurred in the LSNAP arm of the MAP 1 and 2 trials, about 16% in the LSNAP arm compared to 1.9 and 8.7% withdrawal in the MDMA-assisted psychotherapy arm. At least one known instance, a participant who suspected they were receiving LSNAP treatment withdrew from the study, so that is documented. Next slide, please. We've heard the introduction, and now there has been concerns that MDMA heightens suggestibility and lowers judgment. And for this reason, in the phase 2 and 3 trials, there were pairs of therapists, both male and female, to reduce this risk. Despite these measures, in the phase 2 trial, there was a widely reported serious event where a therapist sexually assaulted a patient. This led to the suspension of phase 2 study to review safety and compliance. Next slide, please. The report does summarize a lot of additional outcomes. However, due to the considerations, considerable uncertainties about these seemingly positive trials, we will not discuss the results of the secondary and exploratory outcomes like the functional disability, depression symptoms, but they're all summarized in the report. Next slide, please. When we talk about the second question, which is MDMA-assisted psychotherapy versus trauma-focused psychotherapy, there were lots of differences in study design, baseline medication use, patient criteria, and therapies themselves that made direct comparison of effectiveness between MDMA-assisted psychotherapy and other trauma-focused psychotherapy challenging. However, I'm going to summarize 4 points. MDMA-assisted psychotherapy has demonstrated a moderate to large treatment effect size for reducing PTSD symptoms, which is similar to the trauma-focused psychotherapy versus usual care. Around 40% of MDMA-assisted psychotherapy participants achieved PTSD remission compared to 53 to 63% remission rate when we reported the CPT in a meta-analysis, for example. Treatment discontinuation rate were lower for MDMA-assisted psychotherapy, around 5% compared to some trauma-focused psychotherapy, which can reach 30% dropout. And MDMA-assisted psychotherapy protocol is more resource intense. Remember, we talked about the 42 hours time 2 therapists compared to typical trauma-focused psychotherapy, which is 8 to 20 hours and requires 1 therapist. Next slide, please. There were concerns about the conduct of the MDMA-assisted psychotherapy trials. ICER spoke to a therapist and a small number of patients directly involved in the MAP trials. The experts familiar with the research space. We heard concerns about the conduct of the trials by Lykos Therapeutics, including design choices that could affect the results, interpretation, and potential misconduct. There were strong prior beliefs about psychedelics' value among trial participants and therapists, which could have led to pressure to report favorable outcomes. and severe negative outcome being downplayed or underreported. There were also instances of patients prevented from participating in long-term follow-up. Next slide, please. Discussing some controversies and uncertainties. Trials likely unblinded, making control comparison difficult. We do have potential biases in reporting of the benefit and harm, and I'm not gonna talk about, there are lots of details in the report, and I wanna specifically direct you to section 2.1 here, which is a pretty unusual section, I would say, because ICER typically does not conduct primary research or try to collect primary data. But due to the unusual context, we felt that was needed, and that's why section 2.1 is there. CAPS-5, while it's very commonly used in this space and in the similar trials, it may not fully capture PTSD changes for certain populations. We did hear from patients who told us that while CAPS-5 was looking better, I was feeling that my PTSD symptoms were worse. And we realized that not only that there is limitations to CAPS-5, but also that there are all additional comorbidities that also are associated with PTSD. There is a small sample and short follow-up that may underestimate harm, and then implementing MDMA-assisted psychotherapy could be very challenging for healthcare system. Next slide, please. When talking about benefits beyond health and special ethical priorities, we have substantial unmet needs despite currently available treatment. Women, veterans, and racial and ethnic minority groups in the US have higher burden of PTSD, and if efficacious, MDMA-assisted psychotherapy may have potential to reduce health disparities. The extent to which MDMA-assisted psychotherapy may impact caregivers' quality of life and functioning is unclear due to the uncertainty around the therapy's effectiveness in reducing patients' PTSD symptoms. Next slide, please. So, in summary, the MAP trials showed improvement in many patients treated with MDMA-assisted psychotherapy with few short-term harms. While this suggests MDMA-assisted psychotherapy could be an important addition to the PTSD treatment options, there are concerns about the validity and generalizability of the results. Multiple experts believe that additional trials are needed to prove the benefits outweigh potential harms, despite being hopeful about using psychedelics for PTSD. ICER cannot assess the frequency of misreporting benefits and/or harms, and thus the overall net benefit of MDMA-assisted psychotherapy. We continue to believe that it is vital that regulatory bodies investigate these issues since ICER is unable to assess them. Comparative studies of MDMA-assisted psychotherapy against gold standard trauma-focused psychotherapy are really necessary to evaluate its efficacy and guide clinical implementation. Next slide, please. Because of all that, we evaluated that the current evidence for MDMA compared to the LICO-specific non-assisted psychotherapy for adults with moderate to severe PTSD, we rate the evidence as insufficient, and hence we rate the evidence of the direct comparison in the trials as insufficient, and we didn't have any direct comparison of the MDMA-assisted psychotherapy compared to short treatment trauma-focused psychotherapy. We also rated that evidence as insufficient. With that, I'm gonna move next to some comments that we received in response to them, and I would like to hand it to Dr. David Rand, ICER's Chief Medical Officer, to discuss that. Thank you.
Thank you, Reem. We, of course, received many comments on our draft report. I want to highlight issues raised in two of them from people involved in the research on MDMA-AP. The first was a letter signed by more than 70 people who worked on the phase 3 trials and felt that aspects of the ICER report were unfair and that we should have reached out more to those who conducted the trials. And you can see that comment here. When ICER has questions best answered by trial researchers, the manufacturer who sponsored the trial is essentially always our way of connecting with those researchers. In the absence of manufacturer engagement, researchers are nearly always unwilling to discuss issues with ICER. As discussed elsewhere in the response to comments that are online, we repeatedly attempted to work with Lykos, and they were unwilling to engage. We want to be sure to fairly represent the concerns of those who conduct clinical research. We also have an obligation to fairly represent the concerns of those patients who participate in clinical trials. We agree with the difficulties of the information provided in section 2.1 of the report, and that is why that information is separated into its own section. However, it also seems vitally important not to disregard information provided by trial participants. ICER has little ability to go further in the absence of manufacturer cooperation. ICER has no regulatory authority and is primarily a consumer of publicly available information. Even had there been cooperation, we are not capable of performing a comprehensive investigation when issues are raised around trial conduct. However, we are able to highlight when such concerns contribute to our uncertainties in interpreting trial results, as occurred here. The difficulties that can occur when faced with such conflicting reports from stakeholders is highlighted by the next comment. Next slide, please. You can see that the first section here is quoted from the ICER report by the principal trial investigator. Some patients were prevented from entering the long-term follow-up study and felt this was done to keep these negative outcomes out of the data set. The principal investigator of the MAP trial then responds, "This is untrue. No participants were prevented from entering the phase 3 long-term follow-up study." ICER then responded, in our response to comments, "We had firsthand reports of such events. We cannot be certain that these reports were accurate, but we do wonder whether the principal investigator is certain that this could not have occurred." After this response was published, a participant in one of the trials sent us documentation of an email exchange where it appears that the principal investigator excluded the patient from the long-term follow-up study. While it is not within ICER's ability to fully investigate this email trail, the patient reports they have submitted this exchange to the FDA. Next slide, please. Thank you, and I'll turn it back over to Dr. Mustafa.
Can I, Dr. Mustafa, do you have anything else to add, or should we move to questions?
No, please go ahead and move to questions.
I guess I just wanted to, first of all, Dr. Mustafa, thank you and the whole research team and congratulate you on such a rigorous and important report. So we're grateful. I guess I just wanted to not push back, but sort of probe a little bit about some of these conclusions. So obviously we have a situation here where we have evidence from randomized controlled trials with the highest standard of comparative effectiveness evidence conceptually. So a lot of our deliberations today presumably are going to revolve around these questions of methodological rigor to these trials. So on that note, so obviously blinding is always preferable. You know, blinding of both clinicians and participants is preferable. But, you know, it just seems that there's a lot of areas in medicine where blinding is just not feasible. It's commonly not done. There are some areas where it can be done with, you know, sugar pills or so forth, but there's some things like this that it really can't be done. So it's not at least immediately clear to me how this could have been done differently in a way that was blinded. So we just would love your thoughts about that.
Yeah, thanks, Jason, for this question. I'm glad you kind of mentioned it. So there may be two concepts I want to highlight here. The first is you're absolutely right that blinding is not always feasible. But I do know, we know from lots of empirical evidence actually that in any space where blinding is not done, whether not feasible or just not done, that the results could be inflated in favor of the treatment effect, especially when we have outcomes that are subjective to some extent. Now, granted, and to be fully fair, in the trials, they did try to use the best available tool out there, which is CAPS-5. And that is as objective as we can be in there. However, again, CAPS-5 has limitations. So we are in a situation where not only that blinding wasn't feasible, but there were also other issues. And I also want to comment on one additional topic, which is a concept called co-interventions. So when blinding cannot happen, we pay more attention to what additional interventions that could have happened that may have influenced the results. And we know that more patients in the MDMA-assisted therapy, psychotherapy arm received additional therapy sessions compared to the other arm. So it is very hard to know if all these benefits that we're seeing are just because of the MDMA-assisted psychotherapy or the additional co-interventions that has happened. And with the blinding factor, it just all adds to our uncertainty. I don't know if, I hope this answers your question.
Yeah, no, that's very helpful. Yeah, no, we certainly acknowledge that there are other areas of medicine where the unblinding has sort of exaggerated an effect estimate. So that context is extremely helpful. Rishi, Dr. Wadera, I think you have a question.
Yeah, thank you. Thanks for that informative presentation, Dr. Mustafa. These were small randomized trials, understandably. And, in reviewing sort of the baseline characteristics of the intervention and control groups, there seemed to be some pretty meaningful differences across sociodemographics, baseline SDS scores, historical use of MDMA, pre-study therapies. I'm wondering in your research whether that made you think about the veracity of randomization in these trials and how that might have impacted your and the team's interpretation of average treatment effects as it relates to MDMA-assisted psychotherapy.
Yeah. Again, thank you for this excellent question. So I'm going to respond first as a methodologist and say that, as you all know, when we randomize, when there are small numbers, it is very plausible that despite perfect randomization that you end up with some imbalance in different arms. That's just part of having smaller numbers. So when we looked at the protocols and but we didn't really feel that there were issues with the blinding. But that doesn't mean that we didn't notice some of the differences. These differences in treatment and the control arm were not heading in a specific direction that made us believe that it would have affected the results in one direction versus the other, but we noticed them. That's why if you read the report and the appendices, we do say for multiple reasons that we do think that there is potentially high risk of bias in the trials. So well noted. I think it is an issue of the small number of patients, and I'm not sure that there's a good way to kind of have managed that until we have maybe larger trials that could deal with this baseline imbalances.
Thank you.
I hope that answers your question. Thank you.
Yes, it did. Thank you.
Also, just hearing this exchange makes me realize how unfortunate it is that Lykos Therapeutics is not participating in the session today, because these sort of technical questions about running the trial presumably would be much easier if they were present at the session. Dr. Ross, Joe Ross.
Thanks, Jason. Dr. Mustafa, that was excellent. I just had a quick question about your decision to meta-analyze the two trials. I do realize they're small. If you look at the primary results of each trial individually, you could conclude that one trial met its primary endpoint and one did not. The one that did not had recruited patients with moderate PTSD, not just severe. I don't know if that was perhaps the reason for it. And I wondered if you found in your review a subgroup analysis that had been reported for just the patients with severe PTSD. And if you could just remind me again, what was the difference in the control arm hours of therapy received? I'm sorry if I missed that in your presentation. I get the sense that there was many, many, many more hours in the intervention arm patients.
So to answer the latter part, your perception is correct. There were way more hours of therapy in the intervention arm. And I know Dimitri is here and maybe he can give us the exact number of hours, much shorter in the control arm. But to go back to your other question about our decision to pool, typically we like to pool when to have an overall estimate of effect. We did not have reasons to believe that the results were inconsistent. The results were consistent, but one of the trials crossed the line of no effect, which is just a function of small numbers. And we did not also have reasons to believe that there is a true subgroup effect, that, you know, the medication works for only severe and not for moderate. But we want to highlight that the proportion of patients with moderate PTSD was much, much smaller. It was a quarter of one of the trials. So we know that, but we don't have enough data or numbers to even look at all that separately. There was a group with dissociative PTSD that has been highlighted a priori and looked at, which is a more complex, the way I understand it, PTSD. And there was also treatment effect in that group. So per what we have to date, we don't have reasons to believe that the medications would have worked differently or the treatment would have worked differently, the MDMA-assisted psychotherapy for severe versus moderate, but we need more data. And I maybe take a minute and just see if any of the clinical experts would like to say something about that.
Do either of the clinical experts have a comment about that?
I just echo Dr. Mustafa, given that the moderate group is a small portion of one of the trials, I think it's hard statistically to actually make a conclusive statement around that.
Thank you. Don, I think you have a question.
Thank you. I'm not sure if this is a question for Dr. Mustafa or Dr. Rind. First of all, thank you for this very lucid bit of discussion of this report. I'm looking at the evidence rating matrix, and I note that the ICER report gives I guess, a letter grade of I, which is insufficient. And I'm wondering why the report doesn't conclude that the result here is promising but inconclusive. And as best I can tell from a sort of a literalist view of the matrix, the I grade at the bottom of the matrix admits of the possibility of negative net benefit, whereas the promising but inconclusive grade doesn't really move into that quadrant of the matrix. Is that the reason you chose not to assign a promising but inconclusive value to your analysis here? I just want to clarify that so that
we
know
generally
exactly why you did that.
Thanks, Don. We generally consider promising but inconclusive to mean that on the order of that the degree of harm, and these, it's funny in a matrix, but you might say that 10% harm, we've said this all kinds of different ways. If you're worried that the harm could be large and the benefit could be large, which is, I think, where the team ended up, we're going to end up giving an I rating. So if we can't know, if we think that the harm could conceivably be big and the benefit conceivably could be big, we're going to end up with an I rating in that setting.
Thank you. That's what I thought you were trying to communicate. So thank you.
Thank you both. Are there other, I have additional questions. I just want to make sure I let my colleagues have a chance as well. Are there additional questions from the panel? Dr. Coopers.
Hi, thank you, Dr. Mustafa. I'm not sure if this is a question for you or for one of the other clinical experts on the call, but my question was pertaining specifically to the CAPS-5 and that mean difference, the pre-post-test difference of that 10.18. It looks like that just enters into that range of clinically meaningful at 10. Is that something that is comparable to other trials in this area of having a different score of 10 or 10.18 being meaningful?
Well, Dr. Cooper, I'm glad again you asked this question, all excellent questions. And I would love to hear from both Jessica and you are about that, because I know we've had lots of discussion discussing this. So why don't we hear from them?
Hi, yeah, great question. So I think I want to kind of give context about that 10-point difference. So first, there's not like a universally accepted, like this is the difference in a CAP score that we think is what is needed for an effective treatment. So that's one thing that makes it tricky. Something I want to highlight that I think is important to remember is that remembering it's like a medication-assisted therapy model, not a medication model. I think often we're used to interpreting like a medication versus a placebo, in which case 10-point would still be meaningful, but wouldn't be like the most rigorous bar. So what I personally find to be impressive about this 10-point difference in these trials is that both groups are receiving a really high dose of therapy. Again, as the report notes, it's not a evidence-based or standalone therapy that's been researched outside of MDMA therapy. So that kind of complicates interpretation a little bit. But we do have, across multiple trials, this with the placebo plus therapy group is showing pretty strong PTSD response. So about 14 points on the CAPS. So that 10 points is beating 42 hours of supportive therapy for PTSD. So I think that's the point to kind of keep in mind about it, and like why I think it is kind of a notable finding in this context is that you're seeing that's 10 points above and beyond what the other group is finding, and both groups are receiving what I think it's 42 hours of therapy with two therapists.
I would agree with Jessica that the standardized mean difference of 0.8 is quite good. I would say that it's largely equivalent to the effect size estimates we see with already existent evidence-based treatments that we have for PTSD. But on a general note, I would say that the definition of clinically significant change defined as a change of 10 points on the CAPS-5 is quite lenient. So if you have a specific patient who achieve a 10-point change on this instrument, they will probably experience some change in their life, but they will still be highly symptomatic with PTSD symptoms in many cases.
Thank you both. Austin, Dr. Fract, I think you have a question.
Yes, this is not related to the current discussion, so I'm changing topics. Is that okay?
Absolutely.
Yeah, so I believe just kind of circling back to the question of the number of therapy hours in the two arms, are we uncertain about the number of therapy hours in the two arms and whether they're different? I think that has high significance for our deliberation, so I'd like to be clear on that.
So my understanding, I'm sorry, Reem, do you want to go?
You can go ahead, David.
My understanding is that people had an option in each arm, or the therapist had an option, I'm not totally clear who it was, to do additional integrative sessions, and that many more of those integrative sessions happened in the patients in the MDMA arms than happened in the LSNAP arms. And so to the extent that there was concern about differential co-interventions, it's that unblinded patients, essentially, and unblinded therapists made a choice to do more integrative sessions with the patients who had gotten MDMA, for whatever that's worth. So I don't know how to think about that in terms of hours, but it shows the problems of what happens when you don't blind. And just coming back to the blinding questions, because this has come up over and over again, lots of trials end up in situations without blinding, and we've gotten lots of things wrong in medicine because we did unblinded trials. In the cardiology space, Jason, I could ask you whether stenting helps angina or not, and what the differences were with blinded and unblinded trials of stenting. But I think if you're going to do unblinded trials, you want everything else to be perfect. You know, you really want not to be worried about anything else going on once you have an unblinded trial. And that's what really gave us fits as we were reviewing this, that we had all this swirl of other things calling into question, plus an unblinded trial, which makes it much harder than if you just had a otherwise very clean unblinded trial.
Yeah, thank you, David. And I think you know the answer to your question, but the story in cardiology is that the effect estimate changes. It looks more significant when you're unblinded, which is part of, I think, the issue we have to struggle with on this topic as well. Maybe we have time for one more question. Okay, I guess maybe I'll just add the last one then. Can any member of the research team, or maybe Dr. Mustafa, comment on the directionality of bias, or the mechanism of bias around? There's reports that there's a lot of enthusiasm among the therapists for MDMA. Were the therapists the people measuring the outcomes, and if not, how would that bias have translated into the differences in outcomes that we see?
Yeah, so depending on different outcomes, but the patients reported their CAP score, or and again, as I mentioned, we did hear from patients who said my CAP score numbers were looking better and I was feeling worse. So that made us question some of where the actual tools used actually fully evaluating how the patient experience is. But back to, in any space, not only this space, when you have high anticipation of a positive effect for a new treatment, lots of excitement for a new treatment, we worry that whether it's the people, participants in the trial, or the therapist, would have been too enthusiastic to over-report positive impact. And in a space where, again, not blinding, lots of co-intervention, additional sessions, it was quite hard to determine that the positive effect we see is truly the effect of MDMA-assisted psychotherapy, or is it the effect of all these additional potential biases playing into finding this positive effect. And that's why we ended up with the I rating.
Thank you so much, and congrats again to you and the whole research team for your rigor and detail in this report and presentation. With that, we're gonna, or I think Dr. Maples-Keller wants to make a comment.
I definitely echo, like obviously blinding is very complicated in this area, and having, most or 40% of people having had MDMA, does that suggest these kind of strong beliefs in the treatment? I do want to just highlight the CAPS is not a self-reported measure. It is a clinician rated measure. So I think that, the person providing responses, but a clinician is administering it and scoring it. So clinical judgment is in that they were administered by an independent assessor, so we're not administered by the therapist. So echo the points. I just thought that was an important point to note as we're kind of balancing all these different complicated.
Thank you so much. Appreciate it very much. With that, we are transitioning to the presentation of the evidence in the economic modeling, and this will be led by Dr. Brett McQueen. Go ahead. Thank you.
Yeah, thank you, Dr. Wasfi. I'm Brett, Associate Professor at the University of Colorado, and I'll be presenting the economic evidence. Next slide, please. Just want to acknowledge the whole ICER team and the team here at the University of Colorado, Antal Zemplini and Mike DiStefano, and I have no conflicts to disclose. Next slide, please. So our objective for this is exploratory in nature. We just had this discussion about the I rating And really what we're going to assume moving all the way forward here in this presentation is that the results from the MAPS trials are true, and those are reflected in these results. So that's really key as we move forward here. With that said, the exploratory analysis compared the cost effectiveness of MDMA assisted psychotherapy to no short-term intervention for PTSD, as estimated by the effectiveness of the control arm or Lykos-specific non-assisted psychotherapy. Next slide, please. One way ICER is presenting unmet need now is including both absolute and relative or proportional shortfalls in quality as well as quantity of life using equal value of life years. And really the idea behind this is we're presenting what would be lost for a patient if a particular condition goes untreated. And it's really helpful to have other example conditions. So you can see that PTSD has a lot of similarity with major depressive disorder and is somewhere in between osteoporosis and multiple sclerosis in terms of the average per patient, absolute, as well as relative shortfall. Next slide. Next slide, please. Pretty typical methods that we use in most ICER reviews, decision tree and Markov cohort model. The decision tree is used to capture the short-term effectiveness. I'm going to present in more detail on this on the next slide with a schematic that I think will help with interpretation. And then we use the Markov cohort model to extrapolate the benefits over time. So pay attention to this because later I'm going to present some scenario analyses that kind of reveal this interpretation a little bit better. We use a cycle length of 1 year for both that decision tree that captures the trial time horizon and then extrapolating those benefits every year for a lifetime after that. Our outcomes are fairly typical for cost effectiveness, cost per quality adjusted life year gained, equal value of life years gained. And we have a clinical outcome that we include that is deaths by suicide averted. And I'll present that at a population level, and I'll remind you that's separate from our per patient average level once we review the exploratory results. Next slide, please. Okay, so this is the framework for the modeling. I'll have you start on the left-hand side first, because we're using that decision tree to capture the assessment of response defined by categories of CAPS-5 scores. And so you can see it starts at asymptomatic all the way up to severe. At the baseline in the MAPS trials, patients were allocated to moderate and severe health states. Once the treatment and post-intervention occurred in the decision tree, that distribution was spread out all the way from asymptomatic with a remainder in severe. And there was even a benefit demonstrated in the control arm that we included. Move over to the right-hand side of the figure, and that's where we assign everyone from the decision tree to these health states that are used to extrapolate over a lifetime the short-term health benefits to long-term health benefits. One wrinkle of this model compared to past cost effectiveness analyses is we're including this need for one-time retreatment. And it's only really allocated to those patients in M1, M2, and M3. But based on some longitudinal evidence that preceded MDMA, so it's not related to the MDMA AP evidence, but there was this suggestion of over 5 years with a population that it was at least more similar to the MAPS trials than other studies, there was this need for a one-time retreatment, and the arrow that goes all the way around means that we're reallocating the effectiveness as well as the cost for both the MDMA arm, and then there isn't a short-term cost allocated for the control arm, but I'll get into what I mean by that in a few slides. Next slide, please. There are a number of assumptions that you can find in the report, so I encourage you to go and look at the full table. These are some that we thought were quite important. The cost of the standard of care. So I talked about the protocol and using the arm of the placebo or control arm effectiveness. But in this case, we're trying to reflect what's usual care in terms of resources used. That could be psychotherapy visits that increase as severity increases. That can be antidepressant use, inpatient ER visits. I'll get into how we calculated that in a little bit. While we requested specific and defined CAPS-5 scores across those health state distributions from Lykos, we didn't receive them. So we actually had to do our own calculation and simulation to allocate those patients. And I'll give you an idea of what that looks like on the next slide. Utilities, ideally what I would like as a modeler is to have treatment effects on quality of life. So we have a baseline and we have a follow-up, and I can look at an individual and obviously average level of improvements in quality of life. But based on the first phase 3 trial and only reported in an existing cost effectiveness analysis, we had utilities across those severity distributions. And that means really what this assumption is saying is if you move to less severe states, you improve your quality of life. So we don't really have direct evidence on this. It's more indirect, if that makes sense. Next slide, please. Okay, so this is one of the key areas of the model in terms of the inputs and its effect on the outputs. So you'll start at the left-hand side and you'll see everyone, as I said in the schematic, is allocated to that moderate to severe health state, characterized by higher costs, lower quality of life, and I'll get into those inputs in a few slides. And then move to the right and you'll see the post-trial distribution. Almost half are now allocated to the asymptomatic based on their improvement in CAPS-5 scores. And then another significant portion are allocated to mild and moderate, with that remainder left in severe. Now, there was improvement in the placebo based on CAPS-5 scores, but we still see about half allocated to moderate and severe and the other half to asymptomatic and mild. Again, we used direct evidence from the trials, but then also had our own calculations to generate these distributions. Next slide, please. At the top row, you'll see the cost of the intervention, which is actually a function of two different resources used. The first is a placeholder price. While we requested a price from Lykos, we did not receive one, and therefore we're using 10,000 based on market analytics. And then the remainder of the 23,000 minus the 10,000 is based on reimbursement codes for the AP part of MDMA. So how much would it cost to do these sessions, and what would ideally be reimbursed based on a paper on somebody who's done a lot of great work in this area based on the MAPS trials. And then on the bottom sort of 4 health states, you'll see as we increase in severity, we see an increase in the costs and the spending to treat PTSD. We had to calculate these ourselves based on a mix of about 3 or 4 different sources, but this is consistent with not only clinical expert opinion, but also some of the evidence that we reviewed. So we calculated these, and they include things like inpatient ER visits, antidepressant use, additional psychotherapy visits, as again, we increase in severity. Next slide, please. The opposite direction is the way utilities are moving. As we start with asymptomatic, we see pretty typical average quality of life of any American, and then it decreases really significantly as we move to mild, moderate, and severe health states. We use these utility scores to calculate quality adjusted life years, equal value of life years gained. So these are really important inputs for characterizing the quality of life of patients with PTSD and by severity. Next slide, please. A few other key inputs before we jump into the results. The first one, I spoke about the annualized retreatment in the model schematic. And it's important to note again, we're doing this one time for a patient within the first 5 years based on some longitudinal evidence. It's about 6% per year. So you'll see it in the results, and I'll explain it in a couple of slides. And then the final 2 rows there are very important because we include an all-cause excess risk of PTSD mortality, as well as a death by suicide mortality risk. And we, in the end, sort of had a way of validating this using CDC data on deaths by suicide. And so that's a really important part of this in terms of life extension. And just knowing that the treatment MDMA and the trial didn't directly measure mortality, so we're indirectly including it in the model, again, by shifting the distribution downward to less severe health states. Next slide, please. Next slide. Thank you. Okay, let's start on the far left-hand side. So remember, we're back to, these are exploratory. This assumes that all the results from the MAPS trials are true, and we're using this placeholder price of $10,000 per course. That includes the sessions, all the sessions for MDMA use. So why the 28,000 versus the 23,000? That's because of that proportion of that are being retreated. So we're adding a little bit of costs for that first 5 years along with the effectiveness. It's a small proportion, so it doesn't show up as a large average per patient cost. Then you'll see in the non-intervention cost, there's this cost saving component where we compare MDMA AP to placebo and it's less costly. Why is that? Remember, we're shifting everyone in terms of severity to less severe health states. And as you saw, the costs were increasing, right? In the inputs, you then receive that cost offset for the patients in the MDMA AP arm. For a total cost saving scenario for MDMA AP, again, using the placeholder price in this exploratory analysis. The middle PTSD-related deaths by suicide per 100,000 people output is the only output that's presented at a population level and not at an average per patient level. And the reason for that is it's a little bit difficult to interpret based on the number of deaths by suicide that happen each year in the United States. It makes that number really just not interpretable. So that's why we include it as per 100,000. The far right-hand column, far right-hand 3 columns, excuse me, includes qualities, life years, and equal value of life years gained. You can see across all of those outcomes in this exploratory analysis that MDMA AP has improved health benefits over placebo. Next slide, please. So as expected, at that placeholder price, we would see, as I just presented, less costly and more effective scenarios for MDMA AP versus placebo. And that's across qualities gained, life years gained, equal value of life years gained, as well as that clinical outcome, cost per death by suicide averted. Next slide, please. We ran a number of sensitivity analyses. I think it's important to note that it's really hard to create a tornado diagram with a negative ICER, where you have a positive health benefit and a negative cost. So we've split these, and you can go into the report, which is live, and you can see it right now, and we've included a separate tornado diagram for qualities, equal value of life years, as well as costs. This one gives an example of incremental qualities per person for MDMA AP versus placebo. And we isolate each input to assess the impact on the output. And we can see these would be pretty typical. I've been speaking a lot about the post-intervention health state distributions being key driver. Hint, hint, this is exactly displaying this sort of key driver, the proportion of mild, moderate, severe, all really driving incremental quality adjusted life years, as well as health utility for severe PTSD and some of these other ones that you can see on the left-hand side are also key drivers. So again, you can go and view the other one-way tornadoes in the report. Next slide, please. So we also varied all of the inputs or a set of inputs at the same time and iterated the model over thousands of times while using that placeholder price of 10,000, just to assess of those iterations, what proportion would be cost effective at the different levels, 50, 100, and 150,000 per quality, as well as equal value of life year gained. Again, this is exploratory and at that placeholder price, but we found that 100% of those simulations were cost effective at all 3 threshold levels. Next slide, please. So this is pretty key slide in my opinion, because as our exploratory results suggested, the benefits of MDMA AP really are more effective and less costly, and that's a positive cost effectiveness scenario. We also included a modified societal perspective analysis where we included indirect costs. So that would be lost productivity, that would be caregiver burden and time costs. So just some examples of those inputs included, which in the end will create a more favorable in terms of reducing the cost scenario. So that remains less costly and more effective. But I want you to pay attention to the far right 2 columns, because those are the 2 scenario analyses that I think are most important. We're right around that 150,000 per quality and equal value of life year gained line at 3 years. And then we move, once we get to 5 years, to 81,000, so below the 100,000 per quality and equal value of life year gained threshold. So you can see that the short-term results as we extrapolate further and further in the future, they start moving from non-cost effective to cost effective to cost savings. So this is back to that original exploratory analysis. If the results are true, not only now, but if they are true in the future, longitudinally, where the treatment is continuing to benefit patients, you will see that less costly, more effective scenario. But it does hinge on that. That's one key scenario analysis, in my opinion. Next slide, please. So we ran into a number of limitations. We did request the change in the distribution post-intervention from Lykos and did not receive it. So that's, in the end, why we simulated using the CAPS-5 scores. We also did not find an observed treatment effect on quality of life. We really didn't find a lot of information on how the utility scores were collected outside of 1 to 2 cost effectiveness analyses. And then I think for an area for future research is no doubt there's no evidence on MDMA AP versus other short-term trauma focused therapies. So that's really going to be a key in understanding what other short-term focused therapies could provide benefit. Next slide, please. So we received a number of comments. I would say the first one was really focused on spillover effects. So substance abuse disorders, we completely acknowledge that's not included in the model. However, in the MAPS trials, people with moderate to severe substance abuse disorders were excluded. So it was very difficult to assess whether that treatment effect would be applicable to patients with more severe, moderate to severe substance abuse disorders. So that's another area of future research. And then we also received comments on not only mortality, but other inputs across PTSD severity states. We agree 100%. This is an area that's just really understudied, and understanding the levels of severity, the heterogeneity in the population. So a lot of our own calculations, while they're a mix of sources and we appreciate people cite this and improve it, I think there's a lot of area for future research here that is really could be positive for the field. And then finally, a correction that one of our earlier draft reports erroneously said that we didn't include caregiver burden in our modified societal perspective, but we did, and the evidence clearly states that. So that's an error on our part. One final comment that's not listed on this slide is really we requested, in fact, we received a comment from Lykos on using an inappropriate production cost of MDMA during one of our very preliminary analyses. And then we had requested a price for the MDMA therapy itself, not the AP part of it, and we didn't receive it. So that's, in the end, why we ended up using the placeholder price for that. So next one. In our exploratory analysis, so again, assuming the results are true from MAPS, MDMA AP provides clinical benefit in terms of gains in qualities, equal value of life years, and deaths by suicide as compared to no short-term intervention. A lot of the key drivers were those improvements in the symptoms. The shift in the distribution that I've been talking about you're probably tired of hearing me talk about it for 20 minutes, and then quality of life, and I would add cost offsets as well, are really important in terms of PTSD-related symptoms. And I believe I will take questions now.
Thank you, Brett. Congrats to Dr. McQueen and the whole ICER Health Economics and Decision Science team. We do have some questions already. Austin.
Yeah, thank you. So if I'm understanding correctly, the control arm in the trials and the control arm for the comparison, I'm not sure what the terminology is, for the cost effectiveness analysis is quite different. But the intervention effect is held to be the same. And I'm wanting a little more commentary about how to think about that, if I'm correct.
I'm sorry, could you repeat that? I didn't.
Okay,
didn't
so
catch
the control arm in the trials is not, it has quite a bit of therapeutic hours, many therapeutic hours.
Yes,
The
okay.
comparison arm that you've used for the cost effectiveness analysis is
Lykos assisted.
No additional intervention for PTSD. Is
Right.
is that different from the control arm in the trials or not?
Well, I mean, I think the key is that the control arm, and as I said, the short-term impact of the effectiveness in the placebo arm was included, but the costs were representative of usual care, so standard of care, typical psychotherapy visits that would continue and really be longitudinal in nature. You would just continue going to see your doctor, and it was unclear to us what was really happening in the control arm, I think, and that became a really big debate among, I think, the whole ICER team is what's really happening in that arm, and there's clearly an effectiveness to it, but how would we represent that in resources used? We just didn't have a good answer, and I think that's why we ended up falling back to the typical resources that would be used in standard of care or usual care for PTSD. So I don't know if that totally answers your question, but it's a really interesting nuance that I think we all struggled with. So,
Steve, I think you have a question.
Great. First, I thought it was a really exemplary job with the modeling, Dr. McQueen, given all of the uncertainty and very clever approach. My question is about the price of the drug incorporated into the model. I understand it's sort of a big unknown, and the price could be, I mean, 5 times as much as what the placeholder price is. We just don't know. But I didn't see the drug price isn't included in the DSA, and that might be in the fine print of the report that I didn't see. But did you explore how drug pricing may have affected the outcome, and would it, at what extreme of drug price would the therapy no longer be dominant, I guess is my question.
Yeah, it's a good question. I think because of the I rating and the exploratory analysis, we didn't include benchmark pricing in this analysis. We can definitely do that, and it's possible, but my guess is that it would be much higher than what would be charged on the market. And again, I struggle to see it as a price issue, and I think it's more of an effectiveness issue, given the short run, and hopefully I presented that clear enough, given that short run then is extrapolated to the long run, and whether that's really true, I think that's really what this hinges on, rather than necessarily the price, although of course the price is important, and 10,000 for 3 courses would be pretty significant if that's what was being charged. So I don't know if that answers your question, but if you want to have something offline about that later, or if we end up moving past the exploratory stage, I think we can explore something like that. So.
No, thanks for that question. And maybe if I could just append, you spoke to the efficacy and duration of treatment effect. I think, one issue in my mind that makes duration a little more dubious is all of the past use of this drug, presumably illicitly, among the trial participants. And I think as many as 40% had exposure to this therapy in the pet. Now, of course, it wasn't in the context of the trial, didn't include psychotherapy, et cetera. But I'm not as convinced about the durability of treatment. But again, who knows?
Tara, Dr. Lavelle, you have your hand up.
Yeah, thanks. Thanks, Brett, for the presentation. It's very difficult analysis to do given the data limitations and the uncertainty in the trial. I just wanted to clarify, I guess, back to Austin's initial question about what the comparator arm was here, and then how you derived the transition probabilities for that comparator arm. Was it based on the treatment effect from the trial, or did you have other ways that you were driving that treatment effect that you reflected in your model?
Yeah, what we ended up doing was grouping the CAPS-5 scores into those essentially like 10-unit increments, and then simulating the scores, the average scores, using all the uncertainty from the post-trial intervention to generate each distribution. I wouldn't really call them transition probabilities, because no one's moving in between health states after, they're staying there, except for when there's a retreatment and they're reallocated. So that's the only one where there is sort of what you could call a transition probability. But yeah, that was a challenge, but we were able to calibrate. So essentially it's like multiple equations, multiple unknowns. So we took one and calibrated to what was actually reported in the trial, and then all of the rest were simulated so that we were a little bit more confident about the distribution rather than making stuff up. I mean, this was actually based on the CAPS-5 scores and the uncertainty around.
Okay, all right, that makes sense. Thank you.
Yeah.
Additional questions or comments from the voting panel? I actually have one, just because this is coming up again. I recognize that this question kind of delves backwards into the clinical evidence portion of this, but it's coming up again in the modeling. Is that I'd like to hear, if possible, maybe from the clinical experts, more detail about this issue about more therapy in the intervention arm. Is it, obviously, so that's just to state kind of clearly what everyone's kind of thinking here is that is a potential contamination of the comparison between the control group and the intervention group. And is there something about like how the mechanism that might work? Is there something about the administration of MDMA that leads to the need for more therapy, or is there some question about bias among the therapists about how that was allocated? Is there any sense for why that has occurred and how we can understand how serious to take this idea that there was contamination of this comparison?
I mean, we don't have the data, but I think with the MDMA sessions, like MDMA does bring things up. So I don't find it shocking that some people needed it additional or felt it was clinically indicated to give additional integration sessions. I was just trying to find it in the papers, trying to get numbers on it, because in my memory, it wasn't as big of a difference. I thought it was kind of a small subset of people in the MDMA arm received a small amount of additional integration sessions. But I'm trying to pull up the specifics on it because I think it is. Yeah, so it looks like 14 participants, 10 in the MDMA arm requested further integrative visits as permitted by the protocol.
And so I guess from a clinical perspective, obviously, the vast majority of us are not clinicians in this area. So I guess I would think that if the MDMA leads to requests and provision of additional therapy, is that even contamination? If it's something that the intervention actually leads to the potential identification of these needs or provision of these needs, I'm struggling with whether I should consider that a causal effect of the intervention itself versus a contamination of the control and the reference groups. I would love any guidance about that.
Can you repeat your question one more time?
Sure. Yeah, I'm not sure. I struggle to kind of articulate this clearly, so I apologize. But so if MDMA leads to a process through which therapists and individuals with trauma identify the need for additional therapy and lead to more therapy, could that just be simply considered an effect of MDMA? And if so, maybe that's just a causal effect of the intervention itself rather than some contamination of the control group and the intervention group.
Yeah, that's more how I would think about it. And I will say that, within psychotherapy research, that this isn't unheard of, that there is sometimes flexibility written in protocols that we have to balance clinical ethics with rigor, that if someone really clinically presents as needing an extra session or two, balancing that and having some flexibility. So yeah, I think it is plausible what you're saying, that it could be kind of causally related to MDMA, even though we certainly don't have data definitively to speak to that.
Thank you.
So Jason, I would say that you could put multiple different spins on it. One is this positive spin that you just put on it, which may be perfectly right? That the people who got the MDMA became more open to additional sessions that were helpful to them and they got better. The most negative spin would be the MDMA made them feel awful, and so they demanded additional sessions and really needed them because they were in trouble after the MDMA. And somewhere in between would be the therapists knew who was getting the MDMA and who wasn't, and were more open to providing additional sessions and encouraging additional sessions among the people who they knew had gotten MDMA. And all of those are stories you could tell, and maybe there are other stories, but again, it just gets to how we ended up not sure what to make of all of this. It's not that I would try to convince you of any one of those stories versus any of the others.
Right. It sounds like it's hard to tell which one of those potential possibilities, and presumably there are even other possibilities, occurred and was responsible for this difference. We still have 5 minutes. We can move ahead to the next section unless there are additional questions or comments from the CEPAC panel. Okay, seeing none, I'm just trying to make sure I see everything. Seeing none.